Thank you, and I'd like to thank the chairs for this invitation and the organising committee for giving me the opportunity to present on this topic, which is quite important because it's often overlooked, the adrenal causes towards secondary hypertension. I have nothing to declare. I don't have to tell this audience and the meeting that the prevalence of hypertension is consistent at 30% across the world. That's primary hypertension. What we want to do is, with this session, is to make you aware, and I'm sure you are, that the out-of-office clinic measurements or self-monitoring significantly contribute to the overall management. And we really need to confirm that we have hypertension and the measurements are accurate. And that's a separate topic in itself. But here today, we are considering the secondary causes of hypertension, and it's important to eliminate that possibility at the onset with uncontrolled hypertension. There's also an issue to consider a possibility of adrenal hypertension when there is drug resistance, or what we term resistant hypertension, and that's defined as greater than 3 medication. The other condition where we may suspect that there may be an adrenal contribution to hypertension is when it's an abrupt onset or diuretic-induced hyperkalemia. And especially we need to rule it out when the people that are presenting are young individuals, and we're seeing that more and more. We need to be aware that we don't have quite convincing evidence in terms of what is appropriate treatment, but the accurate diagnosis can give us targeted treatment. There are a number of other conditions that I've listed here in terms of, I'm just going to see if I can move my, is that right there? Yeah. There are a number of other conditions that can lead to secondary hypertension, which I'm not going to cover. As we all know, diabetes complications, diabetic nephropathy lead to hypertension, polycystic kidney disease, renal vascular hypertension, and thyroid problems. I'm just listing them so that it's incomplete. They were aware that the definition of secondary hypertension is an issue that we need to be aware of and control. The importance of identifying adrenal causes of hypertension is that there are targeted treatment and that there are appropriate diagnostic procedures which are underutilised. And we're not sure why, but we're hoping that with discussion and with ongoing engagement between patients and physicians, we can change that. And so when we look at the procedures which do help us identify adrenal causes of hypertension, we identified 10 to 15% of individuals who have adrenal origin of hypertension. And that's significant because those individuals can have controlled levels of blood pressure with this targeted treatment. So adrenal hypertension can be dysfunction of either the adrenal cortex or the adrenal medulla. Possibilities that involve the adrenal cortex include congenital adrenal hyperplasia, which is owing to 11-beta hydroxylase deficiency and 17-alpha hydroxylase deficiency, apparent mineralocorticoid excess, familial hyperaldosteronism, primary aldosteronism, which is the most common type, Cushing syndromes, and familial glucocorticoid resistance. I'm not going to touch on those. I'm going to touch on the most common. The dysfunction involving, or conditions which involve the dysfunction of the adrenal medulla resulting in hypertension include pheochromocytoma, which we don't see as often now, but it is still there. And we really need to be aware that we have to target it because the undiagnosed condition can be lethal. And also we have to be aware that hypertension and obesity is associated with increased catecholamine secretion. So we have an issue there in our growing epidemic of obesity is we're targeting excess catecholamine release. So I'm going to only touch on, as I said, because of time allocation, pheochromocytoma and primary aldosteronism. I'll first discuss pheochromocytoma. Screening for pheochromocytoma, it should be considered in patients with hypertensive paroxysmas, sustained apparent polygenic hypertension, and hypertensive crises, which can be induced by anesthesia. The biochemical determinant which allows us to define whether there is a pheo is fractionated metanephrines and catecholamines, which should precede computed imaging studies of the abdomen and pelvis as the first imaging test. If not identified as part of the diagnosis, as I mentioned, pheochromocytoma can be lethal. However, treatment is surgery. It's effective and there is cure, but it's important to regulate the pharmacological treatment carefully, and this is done in combination with the multidisciplinary team to optimise outcome. Adrenal pheochromocytomas can usually be removed laparoscopically, whereas catecholamine-secreting paragangliomas, as my surgeon colleagues tell me, is typically required an open approach. What is important is that all first-degree relatives of these patients should have biochemical testing. And in addition, there's new recommendation now that there should be molecular genetic testing for germline mutations in most patients with adrenal pheochromocytoma and with paraganglioma. So it's targeted treatment. Surgery is the option. However, that is a pretty major decision for the patient. And so we need to be aware that it may not be the immediate goal or the immediate cause of the hypertension, secondary hypertension, but it's still present. You know, I remember doing intra-arterial studies with patients because we were in a hypertension specialist unit with pheochromocytoma. We don't see that as often now. I've rarely seen it with the ambulatory blood pressure studies that I run. I've put this up because it's not adrenal source, but it is an important issue to remember. We all love, myself included, licorice, but we need to be aware of the saying, too much is too good of a good thing. It is a popular European confectionery, and while I was preparing for this slide, I didn't know the fact, but apparently the Dutch consume about 2 kilos per person per year, which is a significant amount. The important thing is it has an active agent, which is, I have trouble pronouncing it, glycyrrhizinic acid, or GZA, which inhibits a key enzyme which is involved, which is 11-beta HSD2N1, which prevents cortisol converting to the inactive form. So it means cortisol is activating the mineralocorticoid receptor. The consequences of that are mineralocorticoid receptors activation will cause fibrosis, hypertrophy, elevated blood pressure, and a whole myriad of other adverse events in terms of increased redox state. And so that's an important point to remember, that when you are looking at your patients, you do ask the question about their licorice consumption. Cortisol levels in our system are 1,000-fold greater, and so than aldosterone. So inhibition of this key regulatory enzyme can lead to overstimulation of mineralocorticoid receptors, which can cause hyperkalemia, metabolic acidosis, and hypertension. Carbenoxolone, which is a derivative of GZA, also inhibits gastric and intestinal prostaglandin breakdown and was a popular treatment for peptic ulcers, which has a similar effect to licorice excess. So it's important to know that you can detect reduced levels of this enzyme or I should say increased levels of cortisol to cortisone ratio in the blood or urine. That's how simple it is, but we don't do it. Okay, so going on to primary aldosteronism, as we have already mentioned, it is the most common form of secondary hypertension, about 5 to 10%. In some regions it can be higher. leading to hypertension. There's greater organ damage or associated with this condition than primary hypertension, leading to heart failure, stroke, non-fatal myocardial infarction, and atrial fibrillation. We forget about that, but increased aldosterone levels have been shown to be associated with atrial fibrillation. Increased aldosterone or mineralocorticoid activation will trigger arrhythmias. It's because of the calcium channels, it's because of the sodium potassium transporter. Screening is simple and should be initiated. As I've already mentioned, there is targeted therapy, which leads to immediate improved blood pressure control and reduced cardiovascular morbidity. We're not screening enough for it. There's an aversion, we don't know why. It's a simple test, it means collecting blood, but it's important to collect the blood in the morning when the patients have been ambulatory for about 2 hours because of the diurnal variation. We have to be wary that there are several factors that can influence the aldosterone and renin results, and that's the type of antihypertensive medication that they're taking. Most antihypertensives will regulate the renin and aldosterone levels other than beta blockers. However, there is consensus amongst the people, endocrinology experts in this area, that doing a baseline level on treatment is worthwhile without adjusting treatment. Patients who have screened positive should then be referred to endocrinologists or hypertension specialists who are targeting this particular condition for a confirmatory test. We don't rely on the blood sample alone. We need to go further. And on that note, it's recommended by the current guidelines that people who are going to be screened for potential primary aldosteronism undergo adrenal imaging to rule out adrenal carcinoma. Unfortunately, adrenal imaging is inaccurate in detecting which is the contributing adrenal gland because it detects small adrenal, small adrenal adenomas, and so can't distinguish between those tests. Adrenal vein sampling is the gold standard, but it is complex and technically challenging and should only be performed by experienced radiologists who are performing many of those procedures. If the patient is a candidate for surgery, then or has bilateral, if the candidate is not if the patient is not a candidate for surgery or has bilateral adrenal hyperplasia, then medical therapy with spironolactone or eplerenone is indicated. These are simple tests. However, they're not performed regularly. And what we'd like to encourage, in summary, is that you do consider this a primary cause. It is high in certain populations, and we don't know what the true frequency is because we're only seeing referred patients in the specialist centres. Thank you very much.
Thank you very much for this clear presentation.